What is up, you guys? Welcome to another episode of Fundamental Health. I am Paul Saladino. I'm so stoked to have a brilliant OBGYN physician, a master of women's hormones and all things thyroid, pregnancy, lactation with us. This is Dr. Jaime Seeman. Thank you for being here. It's a pleasure to have you.
Thank you for having me. I'm super excited. This is a topic that needs to be addressed in this community.
It absolutely does. And I think that there are a lot of women in the community and their partners that are going to be very excited that we can kind of break this down for people and demystify some of this. The reason I wanted to have you on is because there's such a misunderstanding in the ketogenic and the carnivore communities that a ketogenic or a carnivore diet is going to be bad for your thyroid, bad for your cortisol, bad for female cycles and ovulation, that you can't do it during pregnancy and breastfeeding. And I think that we're going to dig into all those for people today and sort of talk about why that might not be the case, and just do some basic education about how all those systems work. So it's going to be a little complex. This is definitely going to expand people's brains. We're going to do mini courses on all the hormones, so people should get out their notepads and we'll dig into it. So I think it's so interesting, Jaime. I sent you an article today, and we can start with this. This is just the type of thing that really, I don't know, it kind of worries me in the space that there are articles like this, and I'll do a screen share here and show people the article I'm talking about. So somebody I know on Instagram sent me this today. The name of the article, it's on the website Well and Good. And the article is Why Long-Term Success on Keto Can Be Challenging for Women, according to hormonal experts. And so in this article, there are a number of people quoted, and they say they're worried about women's hormones tanking on a ketogenic diet. So they talk about thyroid, they talk about cortisol, they talk about cycles being interrupted. Let's just start with the thyroid gland. And we sort of talked a little bit before we got on the air about your experience treating women with thyroid. Let's break it down for people. I'm sure that the women and even the men listening to this have had their thyroid hormones checked with their physicians, but let's just go into like how you think about treating the thyroid, what kind of things you test, and how you think about the thyroid for any woman on any diet, but especially on a ketogenic diet.
Right. So I think one big take-home point when we start to talk about the thyroid, though, is for people to understand that just dieting in general has an impact on thyroid function. So it's not totally fair to pick on low-carb and ketogenic diets, because severe calorie restriction on standard American diet can have the same impacts on thyroid. So that's kind of take-home point number one for people to understand. But the thyroid is super important. So thyroid sits right here in our neck. It is the source of major metabolic activity. It certainly is related to our hormones. Estrogen can have an effect on the thyroid, just like the article pointed out. But the number one thing is, if you think your thyroid's affected, first of all, get your labs checked, because you don't really know what's going on unless you get your labs checked. And the second is, are you having symptoms of thyroid dysfunction? Because a lot of people, what I've found is, for me in particular, so a lot of people who don't know my story, I had a history of PCOS. I failed all my glucose testing and all my pregnancies. I had postpartum hypothyroidism after all 3 of my pregnancies. But I was one of those people that was extremely sensitive to, when I had hypothyroidism, what my TSH level was. So TSH is thyroid stimulating hormone, and it's the most common thyroid lab that people would screen for hypothyroidism with. And I could literally tell you, based on my symptoms, when my TSH was close to 1 or when it was above 1. Since being ketogenic, now predominantly carnivore, my TSH is anywhere from 2 to 3.5, and I have 0 symptoms. So I think it's important not only to look at the biochemical markers, but to look at the patient and the symptomatology and really put all the different puzzle pieces together. So maybe we can talk about what thyroid function looks like on a biochemical basis, and then we can talk about maybe how it's affected.
Yeah.
So the 2 most common reasons for hypothyroidism would be an iodine deficiency or autoimmune inflammation, especially in women. So near and dear to my heart, because I take care of women and women's health, women are far more susceptible to iodine deficiency or goiter. And women are 3 times more frequently diagnosed with thyroid cancers and at a younger peak rate. And we do think that that's probably related to estrogen. So we'll talk about hormones in a minute, but let's talk about how men and women are a little bit different. So men are, primary hormone is testosterone, and women, primary hormone is estrogen. So it was actually just discovered, a number of years ago that we actually have estrogen receptors in the thyroid. So we have alpha and beta estrogen receptors in the thyroid. And estrogen can have both a direct and an indirect effect on the thyroid. So it can directly affect it because so I deal with women with what I would call estrogen dominance. So the biggest hormone imbalance that I see in my clinic is people who are estrogen dominant, people who carry a lot of excess adiposity and fat increases their estrogen levels, women who are postmenopausal are estrogen dominant. People who have PCOS, although they have androgenic hormones, when we talk about estrogen and progesterone, they're estrogen dominant. And so estrogen dominance can create a lot of problems for women. And one of those is the thyroid. So when you have excess estrogen, or if you're taking estrogen like a birth control pill, it can increase your sex hormone binding globulin and your thyroid binding globulin. And so that can bind up a lot of your free thyroid hormone that's circulating. So thyroid hormone circulates both bound and unbound, which is free. Almost 99% of it is actually bound. And then you talk about increasing these binding proteins, and you're binding up even that last 1% that's circulating. So that can have a profound impact on the thyroid. It also can have a direct effect because estrogen can increase, what they found is can increase proliferation of thyroid cells. And so that's the theory of why women are more susceptible to thyroid cancers, particularly follicular and papillary thyroid cancers. So progesterone also has an effect on the thyroid. So when estrogen increases thyroid binding globulin, progesterone decreases it. And so in women, we always need estrogen and progesterone essentially to be in balance, which we'll talk about the menstrual cycle here, but essentially in women, you have 2 weeks of estrogen and 2 weeks of progesterone in a normal menstrual cycle. And the menstrual cycle for women is a vital sign. If you don't have a normal menstrual cycle, something is off. And so women should use that as a kind of window to their health, essentially, when we're talking about, are their hormones in balance or not?
And so, yeah.
And there's what I also want people to know is we're going to talk really in depth about a lot of this stuff, but for a lot of people, it might be completely over your head. You're not going to be like a endocrinologist by the end of this video. There's so many other little pieces to the puzzle. Other parts of the diet, zinc, selenium, there's all these cofactors, related to thyroid function, and just obesity and inflammation in general. Like for instance, leptin and leptin resistance can have a profound impact on the thyroid. So with the article, I just think it's unfair sometimes how keto and things get picked on when we talk about some of these things, because there's so many other things that affect it just as bad.
It's such a complex equation. And I think what we'll do in this talk is kind of dive deep and do some education and tell people about these hormone systems. And then as we go through the different hormone systems, don't despair. In the end, we'll try and break it down and give you take homes and just say, okay, that's the granular space. And then we're just going to give you the basics. This is what you need to know as a take home. So, but yeah, in reading that article, they were worried about all these things. And I think, you bring up a great point in the beginning that caloric restriction in general will cause our thyroid to change. Anyone that's talked about fasting, from Peter Attia to anyone else in the space, when you check the thyroid hormones go down. The free T3 goes down, the reverse T3 goes up. And I'm going to show a diagram of the normal thyroid sequence and show you guys what all those things look like in a moment. But, fasting and caloric restriction will change thyroid hormones in a normal fashion. Now, what we will also say in conjunction with that is that it's possible to do a ketogenic diet without doing a caloric deficit. So there's a real difference between people doing a ketogenic diet, having a caloric deficit, and people eating enough calories on a ketogenic diet. You can change the macros, and that can influence physiology, but ultimately it's kind of a delicate equation how we're doing all these things. So if someone is trying to lose weight, if they're actively losing weight, it's not really a good thing to check your thyroid unless you're feeling horrible. You have to check with your doctor. But if you're losing weight, if you're calorically restricting, your thyroid is going to be off, even if you're eating a ton of carbohydrates. It's not going to be the same if you're doing caloric restriction. So that's a great point to bring up, and it's something for people to think about as they move in this process. So if we just go to the basics of thyroid stuff, I'll show this basic diagram and then I'll let you kind of break it down for us a little more. So I think that it's helpful to show people what these terms mean. So when people talk about the thyroid axis, they're talking about this connection between the hypothalamus, which is a portion of your brain, kind of at the optic chiasm in the center part of your brain is the hypothalamus. And the hypothalamus releases TRH, which is thyroid releasing hormone. It goes down through the blood supply in the brain to the pituitary gland, which is sort of this kind of like cluster of grapes. It's a small, gland that sits in the sella turcica in your skull below the brain. And the pituitary gland releases TSH, which is thyroid stimulating hormone. Many people will be familiar with TSH. TSH is something we measure in the blood. As Dr. Seeman and I will talk about, it may not actually be the best measure. It may not be super accurate. And then the thyroid gland here is in your neck, clearly, and that's where the TSH binds to receptors, and then you get T3 and T4 made. Generally, the thyroid gland makes mostly T4, and then in the peripheral tissues, T4 is converted to T3. So we can talk about all these processes and the fact that there are deiodinase enzymes that are needed to convert T4 to T3, but generally it's the T3 that's most active. And so when we're thinking about thyroid hormones, a lot of the drugs we use, like levothyroxine, Synthroid, are just T3. And I know we'll go into this. Then there are other preparations that have T3 and T4, and sometimes people don't convert T4 to T3 very well. So from a ketogenic perspective, generally what we may see and what people get up in arms about is the fact that for some people doing ketogenic diets, they see a little bit lower T3, or their T3 might drop, but the TSH often stays in range. Is that what you see?
Yeah, it's exactly what I see. And, like I said, I have a history of hypothyroidism, so I've certainly been checking my thyroid very frequently since being ketogenic and going carnivore. And, I've only seen my T3 get as low as like 2.5. I've seen some on the lowest, like the lowest end of normal. But the important thing is that we're not seeing this rise in TSH. So basically what people need to understand is this feedback loop. So essentially what happens is if your body senses that the thyroid hormone is low, it starts pumping out more TSH to try to stimulate more thyroid production. But if we're not seeing that concomitant rise in the TSH, then clearly the body is happy at this level of free T3. And exactly. So the theory, especially with ketogenic, essentially, is that just like repairing insulin, sensitivity, that this could be a new level of thyroid sensitivity. And so maybe this is just the homeostasis of ketogenic physiology. So I think sometimes, especially in, we try to take like standard American diet literature and then apply it to ketogenic physiology, and they're very different. And so it's what I see. I do look at the TSH, but I was pulling some papers for this podcast, and I came across a paper talking about the deiodinase activity and how it is different in the pituitary gland and in the peripheral tissue. So essentially, we have thyroid receptors like in every single part of our body, our heart, our uterus, our brain, everywhere. And this conversion of T4 to T3 happens mostly in the peripheral tissue. And so what's interesting is this article was talking about how you can have peripheral hypothyroidism. So you can actually, and vice versa. So you can have a patient that has classic hypothyroidism symptoms, check a TSH, free T4, free T3, everything appears to be normal, but they could have peripheral hypothyroidism, so they have low T3 peripherally. And I think probably the other way around, you have a patient that centrally looks like they have hypothyroidism at the level of the pituitary gland, but on a peripheral level, they feel good, they don't have any symptoms, and the peripheral tissue is getting what it needs.
That is so cool. I know you pointed out this paper to me. I will show people. I'll do a screen share and show people a few of the points you just made on the video here. This is such a cool concept.
And the other thing is that with a lower T3, it's actually muscle sparing. And we know that ketogenic and carnivore tend to be muscle sparing when we look at, a physiologic level. And so I think there's just some, I know that you, step outside the box quite often, as do I, in the medical community, but I think this is something we need to consider.
That part of that T3 might be the sparing of muscles, and it's not necessarily a bad thing. I love this concept. So I want to show people this diagram again real quickly. And this is exactly what you were talking about, that the T4 and the T3 down here are going to have negative feedback on the hypothalamus and the pituitary. So the body has tons of systems like this. It's really elegantly designed. And the idea is that when the body senses that the peripheral levels are low, these hormones, the TRH and the TSH, get upregulated. But what you're saying here is that in a lot of these cases of people, their T3 goes a little bit low, but they feel good, and it's not probably an issue with the actual T3 peripherally. That we're talking, when we're measuring T3, and we can just clarify for people, we are talking about levels of free T3 in the blood and free T4 and TSH in the blood, which is the serum. There's no test that I'm aware of that we can use to measure levels of T3 at the tissue level, which would be fascinating. But that's exactly what you're talking about, and this is what's so cool. So here's the other paper that you're talking about. So this is the paper. People can look it up. It's a little bit technical, but I think people would be interested. The title of the paper is Peripheral Thyroid Hormone Conversion and Its Impact on TSH and Metabolic Activity. And the idea with this paper is that, just like you are saying, the level of T3 in the blood does not always reflect the level of T3 in the tissue. And I think this is a very strong hypothesis here for what is happening in ketogenic diets. And I love what you're saying there, that it's a little bit misleading sometimes to apply mixed physiology, people eating mixed diets of carbohydrates to ketogenic diets. Now, I think people can create a strongman argument with that and say, oh, that's fine, it's a ketogenic diet, we don't need to worry about it. But if we look at the science, it seems to hold up in this case. It's probably what's going on here is that the peripheral tissues are converting more T4 to T3. We don't necessarily see it in the serum, but we'll see it in the peripheral tissue. We're getting sensitivity to T3 in the peripheral tissue, and the TSH is not rising and people feel good. And so this paper brings up this idea that there is this tissue conversion, and the TSH and the T4 levels in the serum may not always reflect that. So there's probably something else going on, because like you're saying, a lot of people feel good doing this, but the providers get freaked out and they say, oh, the T3 is too low, you shouldn't be doing this diet. And people kind of make a straw man out of keto and say, it's going to hurt your thyroid. When in fact, we see the basal metabolic rate doesn't change, people feel good, they're performing well, the body composition stays good, and they feel great, right?
Right. If you have a patient with lack of symptoms, I think it's really hard to look at them and say that that's, abnormal.
And I think conversely, the reverse could be true. So this might be the take-home point for thyroid. If you are doing a carnivore or keto diet and you feel good, you have good energy, you have good sleep, your basal metabolic rate doesn't seem to be changing, which means you are losing weight or you're maintaining a healthy body weight, even if the T3 is a little bit low, it's probably nothing to get worried about. Now, if it's very low or the TSH is very high, it may be a different case. But the flip side is also true. And I want to point this out to people. We talked about this before we jumped on the air. The idea that if people have normal TSH, and we can talk about the reference range for TSH, if people have a quote unquote normal TSH or a normal T3 or a normal T4, and they don't feel good from a thyroid perspective, meaning low energy, fatigue, the hair is falling out, there may be other things to think about. And that's another thing that this paper is illustrating, that the peripheral conversion of T4 to T3 might not be there and the serum levels might not be reflective. So in that kind of a case, what would you think? If somebody comes to you and they have, and also in this discussion, I would love to hear what you think the optimal range for a TSH would be and whether you go by the normal ranges. But if somebody comes to you and they're not feeling good and the symptoms kind of suggest thyroid issues, but their levels look okay, what do you think about in that kind of a case?
So, we're always treating symptoms. So if a patient has, classic hypothyroidism symptoms, their T3, free T3 T4 is low, TSH is high, then that's pretty classic, hypothyroidism.
Right.
Then we see cases of subclinical hypothyroidism. So we kind of see mostly normal free T3, T4, but the TSH, is starting to rise. And maybe you're just catching it early, in those situations. So I think a trial of, thyroid replacement, I use more desiccated thyroid in my practice. So NP or Armour thyroid, which is, I think you actually said it wrong earlier. So levothyroxine is a synthetic T4 hormone.
Oh, I'm sorry.
Desiccated, that's okay. You were just talking fast. But desiccated thyroid is both T4 and T3.
Yes.
You can replace T3 by itself. Cytomel or liathionine is what that one's called. But I tend to use mostly desiccated, and it's really just because the free T3 is the most active, and so I tend to treat that more than looking at the T4. Now, with that being said, just a fun little fact is I did some genetic testing on myself a while back with 23andMe and downloaded my raw data. uploaded it into some different programs and found out that I actually carry a polymorphism where I have decreased deiodinase 2 activity. So I don't convert T4 to T3 in type 2 receptors. Also, type 1 receptors are less, or type 1 enzyme is less active in females. So talk about like a double whammy. So that's why I got diagnosed with hypothyroidism after all 3 of my pregnancies. So type 1 deiodinase is most active in the liver and the kidney and within the thyroid itself. And then type 2 is more peripheral, like skeletal muscle tissue, pituitary gland, and in the placenta. So it's super interesting that it happened after all 3 of my pregnancies.
That's so interesting. So I think people will appreciate this, but it's getting into we're getting a little granular. We're expanding your minds right now. So I'm screen sharing here. I want to show people this concept of deiodinases. And the idea is that we start with this hormone of T4 up here, which is essentially, levothyroxine or thyroxine. And then we get T3 through deiodinase 2, which is D2 and D1. And then we can also get reverse T3. And people may have heard that T4 can go to reverse T3. And so we don't want it to go to reverse T3. Reverse T3 is something we see bumping up when there's like selenium deficiency or when people are under a lot of stress or they're fasting. So in order to get a full thyroid panel, and I'll be curious to see what you order, I'm going to order a TSH, a free T3, a free T4, a reverse T3, and antibodies, which we can talk about. But I want to see if somebody's shunting their T4 to reverse T3, which is an inactive form of T3. What I want to see is somebody converting, and everyone has a little different ratio, but there are generally established ratios for how much T4 to T3 someone should have. But you want to see this T4 getting converted to T3. And as you're saying, the T3 is really the active hormone. This is what binds in the peripheral tissues, but there are these deiodinase enzymes. And what you're saying here is so cool. There's this polymorphism that you can test for if you've done your genetics. You might want to work with somebody like Dr. Seeman or myself to kind of demystify this because it gets a little bit complicated, but you can look at your genetics and look for a D2, a deiodinase 2 polymorphism. And I'll show you guys here. You can look at this website called Gene Cards. The gene is DIO2. You can search that on things like Promethease. And you can look at your genetics and see if you have a polymorphism in iodothyronine, deiodinase 2, which may suggest that you're not converting the T4 to T3 very well in some of the peripheral tissues or in the placenta. And then you're thinking, oh, okay, so how do you support that, or what do you do for that? So in your case, like, you've got this DIO2 polymorphism, you've got this deiodinase 2 polymorphism. What do you do to support that? What did you have to do afterwards? Like, what helped? If women have that or women are not converting well, what should they do?
Well, so at the time, my doctor prescribed me levothyroxine. So I took that. My TSH came down. My doctor was not tracking T3 levels at the time, and this was before I ever knew that I had this polymorphism. So it'd be interesting to know what my levels even looked like back then. But now I've been tracking it pretty consistently. And my T3 does run on the lower side, but I've reversed my insulin resistance. I've reversed inflammation. I'm at a normal body composition now, and I have 0 symptoms. So I think basically, supporting your own physiology to the best of your ability. And then that's where medicines fill the gaps, right? When you can't get there, they're not the first line therapy. The first line therapy is your nutrition and the things that you can do to impact that. So I don't know, it'd be interesting to know what my T3 levels were back then, but yes, I'm with you. You need to find a provider that's really checking all of the labs. You need to check TSH, total, free, T3 and T4, reverse T3. And yes, we need to check the antibodies to see, because women are more susceptible to Hashimoto's thyroiditis with an elevation in antibodies against their thyroid gland.
And we can talk a little bit about that too. And you brought up something that I just want to circle back and make sure people understand. And I messed this up because I was talking earlier, but there are different drugs that we use for the thyroid. There's levothyroxine, as you corrected me, thank you. It's just T4. And then these desiccated thyroid preparations, which people may have heard of, Armour Thyroid, NP Thyroid, have T3. So you got to work with your doctor on this, but a lot of people feel better on the desiccated preparations because they may not be converting well. They may have this deiodinase 2 polymorphism. And so you've got to know your T3 levels as well. If your doctor is just taking TSH and you're getting levothyroxine, you just don't know how much of it's going to T3. You may not be feeling very well. So it's such an interesting thing. And then we can dig into a little bit this idea of Hashimoto's thyroiditis. But I also want to hear your story, because I kind of skipped over that in the beginning, and it was so cool to hear you say that you reversed your insulin resistance and you reversed these things that you had. And people may not know this. If they follow you on Instagram at Dr. Fit and Fab, it's spelled out. I'll put it in the show notes and we'll repeat it at the end of the podcast. But they'll see that you're super fit and you're generally, like you're saying, doing a ketogenic or carnivore diet. And it's so cool to see you have that experience where by doing a ketogenic diet, in this case, you reversed your insulin resistance and your thyroid is doing great and you're feeling good. So clearly this is not the case, all the time. And in your case, it was very helpful. So let's hear, I'd love to hear a little more of your story and what happened in your experience and how you figured out, how you found keto and carnivore. And then we can dig into Hashimoto's a little bit for people.
Yeah. So grew up as an athlete. I was a college athlete. So I got away with eating really poorly my entire life because I was an athlete. And I got married. I went to med school. My background is nutrition and exercise. That's what my degree's in. And I have a Bachelor of Science in Nutrition, Exercise, and Health Science. But then I go to med school and I get pregnant with my first pregnancy as a fourth year medical student. And I failed my glucose testing. Mm-hmm. And then subsequently failed it in all three of my pregnancies. And then after my third daughter was born, I thought, this is like ridiculous. My dad has diabetes. His parents have diabetes. The writing was on the wall. And I went and had some labs checked at my annual exam following up on my hypothyroidism and found out that my A1C, I had prediabetes. And here I am, like in my 30s, like pregnancy is the greatest physiologic test of a woman. Like if you are going to get diabetes, it's like your insulin resistance will show up in pregnancy. If you are predisposed to cardiovascular disease, gestational hypertension, preeclampsia, like will show up in your pregnancy. So it's a great kind of window on a physiologic level of like, it's a stress test on the woman's body. So I just said, like, I have to like take the bull by the horns in this situation. So I knew I needed to lose weight to reverse my insulin resistance, but I tried a lot of different things. I tried Whole30, I tried paleo, I lost some weight, but I just didn't feel great. I was still fatigued. I was still taking my thyroid medicine. And it amongst the medical community, ketogenic low carb, like isn't like wildly, like no doctor ever recommended this to me. So I just thought, we're just going to do this. My husband kind of looked at me like, okay, let's go. And we first went ketogenic and the weight just like came off so easy. And I started to feel good. My husband's migraines went away. I stopped my thyroid medicine. My A1C was like below 5. I'm like, holy smokes. And so that was just kind of this like eye-opening experience for me. And I'm sitting here thinking like, as a medical provider, like we have this backwards, like this is not right. And so that kind of cascaded into, now I'm in an integrative medicine fellowship. I've always been passionate about preventative care and things like that. But I just think that we have it totally wrong in medicine. Like we need to start figuring out how to prevent and reverse a lot of these things that can be, reversed and prevented. And of course I've been checking my biomarkers. They're amazing. I feel good. And so I just don't know how anybody can say that it's not the right thing for me. So.
Right. So it's interesting to hear that, you were an athlete, so you were active. It wasn't like you were a couch potato and you still got insulin resistance. Like you're saying, pregnancy is a test of a woman's physiology. It does seem that some women and some men are more predisposed to insulin resistance. And I think insulin resistance is such an interesting topic and that a lot of things can cause insulin resistance. There are people that I think that in the insulin resistance world, there's some really strong theories that it's related to inflammatory oxidized omega-6 fatty acids, seed oils. For some people, it seems that overconsumption of carbohydrates alone may trigger some insulin resistance. I really think that in terms of insulin resistance, there is individual variation in terms of what can trigger it. Because we look at these populations like the Catawbans and the Tabaruans, and they're eating a ton of carbohydrates. They don't seem insulin resistant. But people that are predisposed, maybe they have an ancestral, non-tolerance of carbohydrates, and they eat a bunch of carbohydrates and they become insulin resistant. They get PCOS, which is an insulin resistant connected thing. And we'll talk a little bit about that soon. They might get obesity and they see their lipids rise. And as we were talking about a little bit, when you get insulin resistant, whatever is causing it, whether it's excess carbohydrates in some people, or whether it's something originating in the brain, whether it's inflammatory omega-6 fatty acids, the insulin levels rise and you get hyperinsulinemia. I mean, that's one of the ways that we test for it, is fasting insulin. And so what you'll see is that whatever insulin is driving, whether it's hormones, whether it's, we'll talk about later, conversion of, cortisone to cortisol, or conversion to, estrogen metabolites, things like this, the insulin can drive the hormonal cascade. And insulin, in some ways you could see it as like this, this overarching hormone, that if your insulin is too high, or you are hyperinsulinemic, if you have a fasting insulin that's elevated, if you are insulin resistant, then all the hormones are going to be messed up. And it's so fascinating to look at a lot of these abnormalities in women. And a lot of them are driven by insulin resistance and high levels of insulin. And so something like a ketogenic diet can really reverse this, or a carnivore diet. When we take out the carbohydrates for people that have a propensity to get hyperinsulinemic, we see this insulin normalize, and then the hormones kind of go back to normal. Would you agree with that?
Right, 100%. So when I was talking about getting tested, when I found out I had this polymorphism in my thyroid gene, I have like every insulin resistant gene. It was like reading my health history, like on a piece of paper. It was like insulin resistant thyroid gene. It was crazy. So if you guys are geeks and biohackers and you want to know that information, I highly recommend getting your DNA tested and checking it out. But yes, from a women's health perspective, insulin resistance is a huge problem. When women come and they're like, I need you to check my hormones, whether it's people who have PCOS, whether it's, people who had gestational diabetes in their pregnancy, perimenopausal women, menopausal women, all developing insulin resistance. And women are much more susceptible to men. Women tend to be less active than men. And then our hormonal profile also kind of tips the scale in that direction too. So, is low carb ketogenic for everybody? Nope. There's certainly people who have a certain level of carbohydrate tolerance. I don't, and a lot of my patients don't. So, I think it's something that we really, really need to look at. And yes, from a hormonal perspective, a lot of times fixing the inflammation, fixing the insulin resistance, and the hormones just automatically correct themselves.
Exactly. I mean, people will often message me as clients and they'll say, I think my hormones are messed up. And I don't know if you approach it this way. I say, okay, hormones are like second. Hormones are very rarely the primary cause of an illness, unless you have a hormone secreting adenoma, unless you have an aldosterone secreting adenoma, or you have a Cushing syndrome, a cortisol secreting adenoma, like very, very often, people, I think, get sold this bill of goods from their providers that the hormones are the issue, and you need to take an adaptogenic herb or something to correct the hormones primarily. But I really try and help people think about it differently, that like the hormones are a really good test of what's going on in your body. They're like a stress test. They're an indicator, but they're not usually the original problem. The original problem usually lies with inflammation or insulin resistance or autoimmunity, and that is driving the hormonal imbalances. Right. Do you agree with that?
Right. And we could, a whole nother show, but like the gut and the microbiome play a huge role in hormone metabolism. So I know I heard you talk about this on, I don't know if it was Ben Greenfield's podcast, but the beta-glucuronidase in the gut. So we see in phase 3, basically detoxification of estrogen, we see increase in, beta-glucuronidase, and then estrogen gets enterohepatic circulation. And these women who have this estrogen dominance, like if their gut is broken, it's even just more of a vicious cycle. Same thing with my PCOS patients. So yeah, they come in and they're like, there's something wrong with my hormones, but their hormones are broken because of their gut problems, their inflammation problems, and their insulin resistance. And if you correct those things, it just fixes itself. You don't have to focus on the hormones.
Exactly. I love that. And I think a lot of women out there are just going to like breathe a sigh of relief right now and think, okay, like work with someone who's going to find the underlying cause of your issues, who's going to look at your gut, who's going to test your insulin resistance, who's going to look for inflammation, and the hormones will correct themselves. Don't stress about the hormones in the beginning. I think that's a huge...
And the thing is, like, here's the problem, is that patients will come in, let's just say with PCOS type symptoms. most obstetricians and gynecologists will say, let's just put you on a birth control pill. Let's put you on ethinyl estradiol, and let's pick a anti-androgenic progestin like drospirenone, and it will fix your problems because you're not having periods. And so this will make you have a fake withdrawal bleed, and it'll increase your sex hormone binding globulin. So it'll bind up some of this free testosterone, and it will help some of your, hirsutism. But it's like putting a Band-Aid on a bullet hole. So if you have hormone problems, like, you don't need more hormones to fix your hormone problems.
Yes. Yes.
Body has the innate ability to make the hormones that it needs to live this perfect homeostatic, like, normal menstrual cycle, like normal everything. Like, your body should be able to fix itself.
Yes. I love that concept. I love it. It's totally true. And it drives me bonkers. I mean, there are so many women out there who are just given these Band-Aid hormones by their physicians who just want to feel like they're doing something. And I believe the physicians are all intelligent and well-intentioned, but they don't think about things from this functional medicine, from this root cause perspective. And these physicians are really, they're treating women with hormonal Band-Aids. Like you said, I mean, they're giving them, estrogens, they're giving them, things to raise sex hormone binding globulin. This is not the problem. The primary problem is not the hormones. The primary problem is insulin resistance. I think this would be a great time. We should totally talk about PCOS. I do want to talk about Hashimoto's just for a moment, and then let's go to PCOS, because I think people really appreciate the discussion around insulin resistance and PCOS and this stuff. But so I know a lot of people have Hashimoto's. They've been diagnosed with Hashimoto's. Let's just talk for a couple of minutes about what it is, how you test for it, and what we can do about it.
Right. So you want to make sure that they're testing for antibodies against your thyroid gland. So TPO, or thyroid peroxidase antibody, is the one that's typically associated with Hashimoto's, or anti-thyroid globulin. And so you want to know if you have antibodies to these. And if you have hypothyroidism and the antibodies are high, you have Hashimoto's. Much more common in women. And the major driver here, my thought, is inflammation. And I've seen patients where we reverse the inflammation and insulin resistance, and their antibodies will essentially normalize. They'll go away.
So cool. That's so cool. People need to hear that, that you
right. So it's kind of like, I tell people, like, I always like make this joke, like, you didn't catch diabetes at the mall. Like, you didn't catch Hashimoto's like off a door handle. You have Hashimoto's because of all these underlying issues, and people don't realize that these things can be reversed and controlled. They really can.
So what kind of stuff have you seen be effective for reversing inflammation? I mean, so Hashimoto's is autoimmune. And from my perspective, one of the benefits of a carnivore diet is that we can remove some of the things that might be triggering autoimmunity and inflammation, lectins, things like this in plants. But right. I'm curious what kind of stuff you've seen work for people to reverse inflammation, to improve the insulin resistance in Hashimoto's. I think people are just going to be super excited to hear about this.
So, like, the first two things I always look at is like gluten and dairy. So there's something that's driving this autoimmune condition. So there's no reason that your body should be attacking itself. Women have more autoimmune diseases, and the thought process, especially after pregnancy, is that when you have someone else's DNA inside of your womb, essentially, you have a decrease in your immune system. And so, because you don't want to attack this other person's half their DNA, right? And so there is some mixing of placental DNA and cells within a woman's bloodstream. And so they think that triggers some sort of autoimmune reaction. Now, I think gut health is number one to look at. And that's why I think a lot of people on ketogenic and carnivore diets, all of a sudden their problems just start going away, because they're taking away some of these inciting antigens or whatever it is. But big ones I always look at are gluten and dairy. So easy thought is to just put them on low carb and ketogenic, and see what the response is like. I think that if you are low carb and ketogenic and the inflammation and autoimmune problems are not improving, then you really need to start looking at, specific fruits, vegetables, whether it's FODMAPs, lectins, whatever. Obviously going carnivore is very easy because you're just like eliminating everything.
Everything.
Just get rid of all.
Get rid of all. Perfect.
Yeah, but but even if you did a trial for like 4 weeks and just to see, I'm always a proponent of like, be your own expert, because the way that my body responds and your body responds and a woman next to me is going to be different. And so it's not just like this one blanket approach, but When people have autoimmune conditions, we have to figure out what, where was the inciting event? Why did they have this inflammation that's causing these autoimmune problems?
And I think this is really the thing that I keep coming back to, throughout all of my training. I think autoimmunity is so fascinating, and I just can't get away from the fact that the first place that we should look is our food for autoimmunity. And like you're saying, people can start with gluten and dairy. They can go low carb and keto, which is going to cause them to cut out probably legumes and a lot of grains. They can go paleo. And if that's not working, then there's carnivore, which, I'm a proponent of this for anyone that wants to try. But one of the things that I really appreciate about a carnivore diet, like I said, is just that it removes a lot of potential triggers. And it doesn't mean people need to be on a carnivore diet for the rest of their life. I think it's doable. But, if we can just get to that, we just need to create a healthy, sustainable elimination diet for people. And that is often the most powerful intervention. People don't need to, I also see these people who get told it's heavy metals, it's Lyme, it's all these occult infections. And I think maybe, but really rarely do I see people for which it is Lyme, heavy metals, or occult infections. It's probably the food first. So before people go down all of these rabbit holes, from a functional medicine perspective, and they're worried about mold toxicity, which is a real thing, I believe, but rare, first figure out what foods are triggering your immune system. And so I think that you would agree with that, right?
Yeah. I've been doing a lot of posts on the microbiome, and I hear it all the time. I have a small intestinal bacterial overgrowth. I have this, I have that, but you have that because of your nutrition, right? I agree wholeheartedly. We have to look at the diet first every time. It's
the easiest thing. It doesn't cost a lot of money. Sometimes when people improve their diets, it costs some money, but people can do it on their own. There's so many free resources, me and you and other people on the internet and, Instagram. I encourage people to look all over the place and reach out to us if you have questions, but there's so many things they can do just from a dietary perspective before they chase all these other things. So, all right, let's talk about PCOS a little bit, what it is. And I think this is so interesting because I'll preface it by saying that I've seen so many clients and I did another podcast with Navarada Gray, who's the paleo pharmacist on Instagram, who had PCOS that resolved when she went carnivore. And I've had many clients who have had PCOS and it resolves on carnivore or keto. And so let's talk a little bit about PCOS, or polycystic ovarian syndrome.
Yeah. So I was told that I maybe had PCOS when I was trying to get pregnant with my first daughter. I had super irregular periods and my doctor recommended to go on metformin. And then before we used Clomid or clomiphene citrate, which is a oral ovulation induction medicine, I actually got pregnant on metformin and then subsequently failed my glucose test. So I wouldn't be surprised if I had PCOS at the time, but clearly I don't have any, signs or symptoms of it. But PCOS essentially is a level of high insulin. It's a horrible name. I'm not really sure why we call it polycystic ovarian syndrome, because these patients come in and they're like, I have cysts on my ovaries. I think I have PCOS. Certainly can be one of the criteria, polycystic ovaries, but it's so much more than that. So it's essentially functional ovarian hyperandrogenism. So we see androgenic hormones, we see high insulin. And what's interesting about the insulin resistance, when you're talking about the physiology of somebody with PCOS, is that the insulin resistance is actually only at the level of the muscle and the liver, but there's not, but not the ovary. And so what happens is we get this excess in luteinizing hormone. We see this excess in insulin. It starts driving up things like DHEA and testosterone. And so these women will have acne, they'll have dark hair growth. We start to see these hirsutism, symptoms, and then we see dysregulation of the menstrual cycle. And so the combination of estrogen dominance, LH excess, and the androgens, they aren't ovulating. And so then they're not ovulating, so they're not secreting progesterone. We talked about how important it was for estrogen and progesterone to be in balance. Their obesity and their insulin resistance, drive a lot of the steroidogenic pathway in the adrenal glands. And so we see excess cortisol. I mean, we just see all these things that we don't want to see. And it's horrible for these women because they don't understand the relationship that their nutrition has with their disease process. They feel like this is just something they're going to have for the rest of their life. They're just like stuck with PCOS. They have high rates of infertility. They have high rates of depression. They're obese. A lot of them have end up developing diabetes and metabolic syndromes, hypertension. And so if we don't catch these things early, and like I said, this is my classic example, is somebody would come into my office And they would say, well, just take this birth control pill. And you're actually making it worse. So now you're giving this patient ethinyl estradiol, which is way stronger than any of the endogenous estrogen that they make. And you're increasing sex hormone binding globulin and thyroid binding globulin. So now you're inducing hypothyroidism in this patient. So we have to understand, if you have PCOS, I'm going to make this super basic. You essentially have too much insulin. And so the best treatment for somebody with PCOS is to figure out how to get their insulin down. And the best way to do that is by dietary restriction of carbohydrates. So low carb or ketogenic diet. And so when you look at the studies on PCOS, I think you might have one pulled up, but, and I think it's probably the one from 2005. So it's a small group of patients, but in the PCOS studies, they almost always limit the carbohydrates to 20 to maybe 25 because they want 100% of the participants to be in a state of ketosis. So, there's probably like somebody like me that was athletic. Maybe my carb tolerance was closer to like 40 or 50, but almost every PCOS patient, if I'm going to do a diet for them, we're almost always looking at less than 25 carbs per day. So it's extremely, restrictive from the typical American diet of somewhere like 250 to 400.
Yeah, right.
But in this study, the patients, like all of them reported infertility, and 2 of the patients got pregnant during the study, which is
surprise.
Yeah, and I have actually seen this in the keto community. Is people all of a sudden will have spontaneous ovulation and menstruation, and people are having like surprise pregnancies. So I, warn people that when you correct your hormones, you're correcting your hormones. So, but in this study, we saw a reduction in fasting insulin. We see a reduction in body weight, reduction in their free testosterone, correction of the LH-FSH ratio, and then 2 of them got pregnant. So, essentially, low carb and ketogenic is the best treatment for PCOS.
It's so crazy. This is so wild. I'll pull up the study here. I've got it. I'll show people. So the effects of a low carbohydrate ketogenic diet on the polycystic ovary syndrome, a pilot study. It is from 2005. And as you see here in the conclusion, the low carb ketogenic diet led to significant improvement in weight, percent free testosterone, the LH-FSH ratio, so LH went down, right, because LH is kind of going up in PCOS, and fasting insulin, so fasting insulin went down in women with obesity and PCOS over a 24-week period. So this is a long study. And if you look up here, some of these other ones are really impressive. The fasting insulin dropped 54%. They had 12% loss of body weight, 22% reduction in free testosterone. So I think that you're completely on the money here. I think this is so cool. I think that the treatment for PCOS is a ketogenic diet. Like, we should call PCOS like hyperinsulinemia. We should just call it like women's metabolic syndrome or women's ovarian, hyperinsulinemia. And then people would think like, oh, well, if we call it something that includes insulin, we won't just give people hormones, and like you're saying, the hormones can worsen things. And we talked about this a little bit in the beginning, and I'll just reinforce it a little bit here. When we give more of these hormones, we can change the thyroid hormone binding globulin, the sex hormone binding globulin, and the estrogens can do this. They can increase these sex hormone binding globulin, increase the thyroid hormone binding globulin. So by giving someone exogenous hormones like estrogen, like you said, you can give them a fake period. They can have withdrawal bleeding, but that doesn't mean your hormones are normalized in any way, shape, or form. And what you're actually doing is creating a hypothyroid state by binding up all this free hormone on these other, thyroid binding globulins. So it's the wrong thing to be doing. I think that we are imagining that we are fixing things, and we're just not, and this is sort of my issue with all of medicine. So yeah, and it was so crazy because in that first article I pulled up, if people read that article, they were even saying in the article that, the cortisol could rise, and we'll talk about cortisol a little bit next. The cortisol could rise. I think there's a fear that on a ketogenic diet, your cortisol is going to get chronically elevated, which we just don't see. The cortisol could rise, and it could cause PCOS. And I just kind of like laughed out loud. I was like, well, actually, it fixes PCOS. So we clearly see that the cortisol is not rising, that the insulin is dropping. So women with PCOS, if they're listening, they should just realize that like, they may be women who are sensitive to high carbohydrates. And if you're able to cut the carbohydrates with a ketogenic or a carnivore diet, I really believe, and I think you would agree, that the PCOS will go away. And just be careful, because you may have a child, whether you want, that could be a great thing, you will get pregnant.
Right. So what we see is even just with like 10% reduction in body weight, a lot of these women will start ovulating spontaneously. And so it is a real concern. I mean, you have to tell them, like, use backup methods and things like that, because it'll happen. But we need to fix, I mean, if a woman comes in with PCOS, we need to fix the root cause, because then what happens is you put her on birth control pills, she comes in, she comes off them, she's not ovulating because you didn't fix anything. Now she needs ovarian stimulation. Now she's pregnant. Here's her gestational diabetes. And now you just increase her risk lifetime diabetes, like probably close to 100%.
Yeah. So that's the other thing that is so interesting, like women on PCOS who are able to get pregnant with just all this like hormonal sort of tinkering, they're going to get to gestational diabetes, which isn't going to help them either. The baby's going to be big, and then you're going to be delivering a huge baby, and they're going to get,
you're changing the epigenetics of their baby. I mean,
exactly.
It's just like,
don't have the baby when you have PCOS. Fix the root cause. It's crazy. Right. So yeah. Let's talk a little bit about cortisol, because I just want to dispel this myth. There's a video out. I did a comment on it from Danny Roddy, who I respect, on YouTube, and he was saying that he didn't show his data. But one of the things I think people worry about with a ketogenic diet, this may be for both men and women, but I just want to talk about this briefly before we move on to women's hormones. That a ketogenic diet is going to raise cortisol. And I mean, and so I mentioned this earlier, but in medicine, when people have persistent chronic hypercortisolemia, we would call this a Cushing's syndrome. And so do you see people with Cushing's syndrome on keto? Because I sure don't.
No, I've never seen it.
It doesn't happen.
Right. Okay. So when you told me about this, I went and pulled some studies, and I think it was Jeff Volek that did the study. And of course, most of the studies done on ketogenic are like 20-some-year-old guys. There's no study on women.
Right.
And because we're just too complex. We'll talk about why. But there was no change in cortisol between the control group and the ketogenic diet group. So I think it was a 2012 study, Jeff Volek. Somebody could look it up if they wanted, but there was no change in cortisol between the two groups. So there's lots of things that raise cortisol. So stress, lack of sleep, overtraining, there's lots of things that raise cortisol. And I'm not really sure what the theory is for raising cortisol on a ketogenic diet, because I've never seen it. And I take care of a lot of patients that are low carb and ketogenic. Now, certainly if you have, severe dietary restriction and other stressors in your life, you can certainly have high cortisol, but it's not the ketogenic diet that's driving the cortisol.
Exactly. And I think that if people say this, when they're criticizing ketogenic diets, and it's just a misunderstanding of this. And this is the problem, is that it all kind of gets conflated, and people just don't understand the way this works. So I'll do a screen share here and show people a little bit about how the cortisol usually works. So cortisol has this diurnal pattern where it's lowest, in the middle of the night, then it spikes right when we wake up, and we get this cortisol awakening response. And so the cortisol is supposed to spike in the morning, and then it kind of goes down throughout the day. And at this time of the night when we're recording this, it should be down here low. And so people may get these like salivary cortisol curves from their practitioners. They may do Dutch or something, and you can see different cortisol patterns. But generally, I think the idea is that we're supposed to get a spike in the morning. That's normal physiology. It wakes us up, and then it goes down throughout the day. And so people will say things like, you are most insulin resistant in the morning, which may be true. And that's probably because the cortisol is higher in the morning, but it doesn't mean that's a bad thing. It's just the way it is, right? So, it's an interesting thing. But, a lot of things can change adrenal function. Generally, when I see people with disordered adrenals, it's because they're not sleeping well and they are super stressed, right? But in the patients that I have on carnivore, when I've done these salivary cortisol things, you just do not see issues with cortisol. They don't have these disordered cortisol curves. You don't see these cortisol curves that are just off the charts or completely weird. And I'm going to try and find this study from Volek, but if I can't find it now, I'll just link to it in the show notes. But Jeff Volek is one of the researchers with the Virta group, VIRTA. They have a blog at Virta Health, and they've talked about this a lot. And they've done studies looking at glycogen levels and glycogen repletion in ketogenic diets. And what they find with that is that actually once you get fat adapted, you get the same level of glycogen storage and replenishment in your muscles as somebody on a mixed carbohydrate diet. So it's this crazy idea. People ask me all the time, they say, what about glycogen? Am I going to be able to do explosive exercise? And at least from a glycogen storage and replenishment perspective, it's the same. And I think it's the same with the adrenals. We just don't see adrenals going bonkers on a ketogenic diet. Your body adjusts. I think people might think of this because in the acute phase, when your body is adapting, so if you are carbohydrate adapted and you're trying to switch over to fat-based metabolism, your body does have to use some of these hormones to do gluconeogenesis in the beginning. But once you get to be fat adapted, you don't have to do that anymore, and your body can go back to normal physiology. So the other thing I would caution people about is that in that article that we looked at in the very beginning from Well and Good, a lot of the studies they reference on a ketogenic diet were done in mice. And I think any study you see on ketogenic diet in mice, you throw it out the window, because mice and humans are very different in the way that they use ketosis. Humans are one of the only species that I'm aware of that can go into ketosis without, when they're still eating. So in mice, to induce a ketogenic state, you have to starve the mice, right? But in humans, you can induce a ketogenic state but just by changing the macros. But it doesn't work that way in other animals. And so ketosis is starvation physiology in a mouse. It's going to have different hormonal responses. Ketosis is not starvation physiology in a human. It's adaptive physiology. And I think what we're learning now is that it's so beneficial from epigenetic perspectives, from weight loss perspectives, from insulin resistance perspectives, from longevity perspectives. Ketones activate the sirtuin genes beyond the scope of this podcast. But humans are uniquely adapted to be in a ketogenic state. It's very different than what we see for people on when we're looking at rodent models. So I would really encourage people to not get confused about rodent models of ketosis and not use those. And I think let's talk about women's hormones a little bit, because I think women's cycles are complicated, and I think we can demystify a little bit of this for people as well. I mean, the question that I get, I think the question that people will want to hear answered is, am I going to be able to have a normal cycle on a ketogenic diet, on a carnivore diet? I hear that I need carbs to have a normal cycle. What do you think about this? Let's break it down.
Okay, so let's talk about what a normal cycle looks like. And so I think you might be able to pull it up. So essentially in a woman's menstrual cycle, in a perfect world, it's 28 days long. And so in the first 2 weeks of the cycle, which is considered our follicular phase, we see more estrogen. And then in the second 2 weeks, or the last 14 days, which is our luteal phase after ovulation, we tend to see more progesterone. And so I kind of explain it to women as we want to be 2 weeks of estrogen, 2 weeks of progesterone. I kind of hinted earlier that one of the biggest problems that I see in my clinic is estrogen dominance. And so especially in patients with PCOS, they don't ovulate, and so they don't get this normal phase of progesterone. And so what you can kind of point to it, Paul, as I talk about it, but essentially what's happening, so estrogen is this orange line. And so the first day of bleeding is considered the first day of the menstrual cycle. And so we see this slow rise in estrogen where it peaks just before ovulation. And right next to that is kind of a paler blue line, which is your luteinizing hormone. And that's what triggers ovulation. And then after ovulation, the estrogen will come down. It will rise just slightly during luteal phase. Now, progesterone is the green line. So progesterone is very low in the first 2 weeks, and then progesterone rises after ovulation. It is secreted from the corpus luteum. And the idea of progesterone is to support a possible pregnancy. And if a pregnancy doesn't occur, then the cycle starts all over again. Now, what's super interesting, and I have been able to kind of notice this myself a little bit, is in normal menstruating people, we see almost a little bit difference in physiology when you're talking about your follicular phase versus your luteal phase. So estrogen in women, we tend to see a little bit more insulin sensitivity, and there's less cravings. Women tend to recover better. So in the first 14 days of the cycle is when women can train a lot harder. They tend to be really great with their diet, very compliant. And then after ovulation occurs and we see this drop in estrogen and rise in progesterone, women tend to have many, many, many more carb cravings. We tend to see kind of this bloating effect. So there's a fluid retention that occurs. They don't recover quite as well from training. And so it's very interesting physiology, and I'm super in tune with my cycle, and my husband knows which two weeks I'm on, because I complain when I'm in progesterone phase. But that's how women's bodies are designed. You're designed to go through these normal hormonal fluctuations. Now, when we talk about the need for carbohydrates, it depends where you're starting from. If you have PCOS and anovulation and you don't have a normal menstrual cycle, low carb and ketogenic is going to get you to start menstruating again so that you can have these normal levels of hormones. If you don't have a period because your body fat's too low, then you can certainly do low carb and ketogenic, but you need to start creating a calorie excess to get your body fat back up, because most women will stop ovulating usually sub like 15% body fat. Women are designed to perpetuate the human species till the end of time. And so the way that the woman's body is designed is to hold more fat in the buttocks and the thigh area. That will be the last fat to leave. This is why we have differences in our thyroid compared to men, because we need to perpetuate the human species. And so there's no reason, there's no essential carbohydrate. You don't need carbohydrates to make your hormones. Your hormones are made from fat. They're made from cholesterol. All of your hormones are made from cholesterol. And so if we looked at that steroidogenic pathway of the adrenal glands and the ovaries, they're all, cholesterol turns into pregnenolone, which makes hormones in all the peripheral tissues. And you don't need carbs. You need healthy fats. And I've seen women who have tried to thrive on low-fat diets for a long time. They're not menstruating. And it's just, it's not what women's bodies need. Women's bodies need protein and fat. And we can talk about, pregnancy and breastfeeding, but there's no reason that you need carbs and insulin. And you can still, we've talked about this numerous times too, you can still grow muscle on a low carb and ketogenic diet due to that muscle sparing effect
of the ketones.
Yeah.
So I've got the steroid pathway up here. Again, this is going to kind of be a little bit crazy for people, but walk us through this a little bit. I'll show people here. Just like you're saying, it all starts with cholesterol. It doesn't start with glucose, right? Like, to make your hormones, you need cholesterol. And then it goes to pregnenolone. And there are all these different enzymes in here. And I don't want people to get overwhelmed, but I just want to show them, walk us through this a little bit for what might be useful for people to see here. Move this out of the way. So here's the steroid pathway. And this is kind of like how men and women make hormones. But let's just walk us through this for women.
Yeah, so let's talk about women. So we talked about the dominant hormone in women is estrogen. And so we see estrogen kind of in this bottom right-hand corner down here. And we have really a couple different types of estrogen. We have 17-beta estradiol, which is the one that Paul's pointing to right now. And that can be converted into estriol, which is E3, or estrone, which is E1. And the most important thing to kind of take from this estrogen little pathway over here is that estrogen is kind of a use it and then lose it type hormone. So we want to have the estrogen. Estrogen is great. It's the reason we live longer than men. It's really good for our heart and for our bones. And, but then we want to get rid of it. And so we metabolize estrogen into 16, 4, and 2. So you can see that 2 pathway down there. That is the most favorable pathway. And so that pathway is where we want, so there's a ratio essentially of our estrogen metabolism, how much goes down that 2 pathway, how much goes down the 4, and how much goes down the 16. The 4 pathway is the carcinogenic pathway. So people that metabolize their estrogen into that pathway are the people who are at risk for estrogen-related cancers, like endometrial cancers and breast cancers. People that push their estrogen down the 16 pathway, this is a proliferation pathway. And so it doesn't necessarily mean cancer, but for instance, if a patient had underlying breast cancer and they were metabolizing a lot of estrogen in the 16 pathway, it caused proliferation of their cancer. And so then what happens is you can see that there's this methylation down here in the 2 and the 4 pathway, where you can see that we have the methyl donor. So I know you talk about this a lot with the glycine methionine ratios and methylation, and we could get into the weeds of this, the COMT and MTHFR. Another side note, I found out I have 2 MTHFR mutations, so I don't methylate as well. So for instance, for me, I don't methylate as well. So, knowing where my pathway is and how I get rid of my estrogen is important. And then after it goes into, after the methyl donor is added, then it goes through phase 3, which is where it needs to be excreted either in the urine or the feces. And it's not on this pathway. But estrogen is use it or lose it. Now, men have small amounts of estrogen too. And your estrogen, Paul, goes through the same pathway. And so some men convert a lot of their testosterone into estrogen. You can kind of see that pathway up there, testosterone into estrogen. And the things that drive that conversion, it's something called aromatase. It's an enzyme that's in our fat cells. So inflammation, excess body fat, and alcohol are the three big things that really actually convert that testosterone into estrogen. And then even as a man,
right?
as a man, you have to, insulin resistance, you have to still metabolize it the same way. And this is why, even in men, that they have an increased risk of prostate cancer if they don't metabolize their estrogen correctly.
Because of the proliferation, like the 16-hydroxy?
Yep, exactly. Estrogen-related cancers. So, but also in women, let's talk about testosterone for a minute. So testosterone can be aromatized into estrogen, like we talked about, but it can also go down another pathway called 5-alpha reductase, which converts it into 5-ADHT, so dihydrotestosterone. This is a much more potent testosterone. And so in this pathway, this is where we see symptoms like male pattern baldness in men, but even in women. And 5-alpha reductase also works on a lot of other things in this pathway here. So if you point to like cortisol gets metabolized either by 5-alpha reductase or 5-beta reductase activity, and so does progesterone. So over on the left side there. And it's important to know what your 5-alpha reductase activity is. So if you think you have some kind of hormone problem, this Dutch test, this one that we're looking at, is one that I use in my clinic. So I think it's a great one to look at. But this is a urinary test that we do. And we actually look at what's happening with your hormones, because everybody pushes their hormones down different pathways here. But I think the important thing to point out, and we should have talked about this when we were touching on cortisol, is that in this pathway here, high insulin pushes cortisone into cortisol, high insulin pushes testosterone into estrogen, high insulin pushes pregnenolone down over into the 17-OHP pathway, which could make even more cortisol. So if you want to talk about, ketogenic diet raising cortisol, I think you're going to have a really hard argument when we can show that insulin actually probably drives many, many, many more things down the cortisol pathway.
And I think this is the thing for people to hear at this point in the talk, is that high insulin levels are linked to PCOS. High insulin levels are linked to testosterone being aromatized into estradiol. High insulin levels are linked to cortisone pushing into cortisol, and progesterone going to 17-hydroxy, or pregnenolone going into 17-hydroxypregnenolone. And so, this is not to say that insulin is not an important hormone. We need insulin. It's not the worst thing in the world, but hyperinsulinemia, insulin resistance, is probably behind most of these issues with people. And so if women, tell me if you disagree with this, but I feel like if women have issues with thyroid, with cortisol, with cycles, they should get a fasting insulin check. They need to know how well they're tolerating carbohydrates. They need to know how insulin resistant or insulin sensitive they are. That would be the first place to start. And as we talked about, probably the best thing to do is to modify foods. I would argue that the first thing women should look at, and men too, is, are you insulin resistant? There can be other things that can drive some of these issues. But if you're insulin resistant, if your fasting insulin is elevated, and I'll be curious to see what you think of as a cutoff of fasting insulin. If I see anybody with a fasting insulin about 4 or 5, I think of them as like, that's not what I want. I want to see a fasting insulin less than 4 or 5. And so people should be looking at insulin. Insulin is probably the hormone that is driving these other hormonal issues. People shouldn't get concerned. They can come to see Dr. Seeman, they can talk to me, they can talk to other functional medicine practitioners, and we can do the Dutch test and we can see where it's all going. But usually what shakes out is insulin or something along those lines. And so it's so interesting.
Right.
So what, for what you've seen on your patients, do you see patients on ketogenic diets have problems with irregular cycles, or are they pretty good?
No, honestly, a lot of patients, we start correcting some of these things and we take them off their hormone or birth control. And I don't see patients with cycle dysregulation on ketogenic diet. I just don't. And patients with menopausal symptoms, a lot of times we can alleviate a lot of their menopausal symptoms by reversing some of the inflammation and insulin resistance. A really good example of this, I had this patient that came in and just had what seemed to be like hypoglycemic episodes. She was having these episodes where she was like getting sweaty and diaphoretic and lightheaded, and she was fatigued, like horribly fatigued, couldn't wake up in the morning, all just hungry. Somebody sent her to an endocrinologist and they gave her a glucometer and she was checking her blood sugars and they're all normal. and nobody could figure out what was wrong with her. So she comes to my clinic, and I said, well, I want you to come back tomorrow for fasting labs. And she comes in for fasting labs, and her fasting insulin was 276.
What?
I was like, there is no way this is real. So basically her pancreas, you guys, is pumping out that amount of insulin just to make her blood sugars normal, euglycemic. So I put her on a low carb ketogenic diet. I had her come back like a couple weeks later. I rechecked her fasting insulin, and it was down to like 52. And
which is still pretty high.
Yeah, which is still like super high, yeah. But she wasn't like 100% compliant with her diet, but we still got a long ways. But insulin can really wreak havoc for a lot of women.
And I think that women think women's hormones. They think estrogen. They might think testosterone. They might think thyroid. I hope that women and men too will also think insulin, and I just think this is crazy. I don't, like, when I get labs from other physicians, fasting insulin is almost never checked. They might check an A1C, they might check a fasting glucose, which should show some abnormalities, but really you can miss it if they have postprandial spikes in glucose. You can't always see. But if you get a fasting glucose, an A1C, and a fasting insulin, and they'll calculate something called a HOMA-IR, you're going to see if you're insulin resistant pretty well. A lot of people don't need an insulin tolerance. They don't need an oral glucose tolerance test. They don't need those more invasive tests to really prove that you're insulin resistant. I mean, if your insulin is low, you are not insulin resistant in most cases. So I think this will be great, and women can look at this. And so if people are trying keto and they're having issues with their cycle, I think that then you have to really go to a provider, because fundamentally, based on human physiology, this should not interrupt your cycle. The question is, are you cutting calories too much? Is your thyroid messed up? Do you have another mineral deficiency? But I would argue, and I hope you would agree, a ketogenic diet is not the cause for your menstrual irregularities. It's not the cause for your thyroid irregularities. We kind of went into the nuance of thyroid, but there could be other things going on. It could be a gut issue. It could be a nutrient deficiency. There are all sorts of things. But to say that it's a ketogenic diet is probably the wrong thing, because what we see in terms of human physiology is that doesn't happen. Because like I said earlier, ketosis is not a starvation state for human. It's an adaptive state. We can run on ketones or we can run on glucose. People will try and say ketosis is a starvation state. That's a conflation of ideas looking at rodents and other animals for whom ketosis is a starvation state. But in humans, we don't have to be starving to be in ketosis. We just need to be not eating carbohydrates. It's not a starvation state. We don't see a rise in cortisol like we talked about. We don't see a rise in other sympathetic hormones, norepinephrine. These hormones do not rise on a ketogenic diet if you look at it. People do not get hypertension on ketogenic diets. Their hypertension goes away. But I want to really disabuse people of this notion that ketosis, carnivore, is a sympathetic, which is, in the human body, we think of autonomic nervous system. There's parasympathetic, which is rest and digest, and sympathetic, which is like fight or flight. Ketosis is not a fight or flight condition. It's just not. There's no sympathetic nervous system activation in ketosis. So if you're having issues, there's something else going on, I would posit, that's triggering that. Would you agree with that?
Yeah, 100%. And I had somebody reach out and ask a question earlier tonight about sounds like they're perimenopausal, so in their 40s, went carnivore, and all of a sudden they're having regular cycles and they're having breast tenderness. And she asked me about the breast tenderness. So that's estrogen. She's fixed her estrogen, and now she's having breast tenderness with her cycles again. So, it's just telling you your body's working again the way it's supposed to.
Yeah, maybe that's good, right? Just be careful, because don't get pregnant unless you want to be.
When you're 40.
Careful. Well, I want to be respectful of your time. Let's talk about pregnancy and breastfeeding a little bit, and then, and then we'll.
So big controversial topic, but I get asked about it all the time because I'm an obstetrician. So when we look at prenatal, nutrition and literature, which, total side note, but in 2020, I don't know if you know that the USDA is coming out with new recommendations, and they specifically are going to look at pregnancy and breastfeeding. It'd be very interesting to see what they come up with. But essentially, the current recommendation for pregnant women is to consume 45 to 65% carbs, which is like standard American diet, 250 to 450 carbs. Uh-huh. Pregnancy in and of itself is a state of insulin resistance.
Right.
The body's job to shunt as many nutrients to this growing fetus as it can. And especially in the third trimester, the placenta starts excreting a lot of hormones that create even more insulin resistance, which is why at 28 weeks in the pregnancy, we test for gestational diabetes. Now, there's some thoughts out there that you shouldn't eat less than 175 carbs per day when you are pregnant. And the thought process is that they took the lower limit required for a mom, and then they decided that the baby needs like 33 carbs per day for brain function, and it's just kind of this arbitrary number. What I find anecdotally with my patients is that most of them are consuming probably somewhere between 75 and 150 carbs during their pregnancies and are doing great. I don't recommend like a really strict, especially if you aren't already adapted. So my recommendation is if you want to go into pregnancy is to get keto and fat adapted prior to conceiving. Let your body be at a steady state before you conceive. I wouldn't just like in the middle of your pregnancy, start doing this, but certainly a low carb and moderate carb diet are completely healthy in pregnancy. What's super interesting, for instance, when we look at gestational diabetes is that we challenge these women with 50-gram glucose tolerance tests. And then when they fail, if they go on to get diagnosed with gestational diabetes, if I send them to diabetes education, they tell the patient to eat a minimum of 50 carbs with each meal. I just gave her a 50 carb challenge test that she failed, and now you want her to eat 50 carbs with each meal. And I get it, you're mixing it with protein and fat, it changes the glycemic response. But it's totally asinine the way that we think about gestational diabetes treatment. Just like 2 years ago, the American College of OBGYNs came out and said that insulin should be first-line treatment for gestational diabetes that can't be controlled with diet. And it's just because we're so fearful of telling these pregnant women that they can't have carbs and then something will happen to their baby. I mean, I get it. It's hard to study pregnant women from an ethical standpoint, but when we look at our ancestral populations, like hunter-gatherers, like they probably only ate between probably like 16 to 20% carbs at most. And clearly, the species, is here.
It's fine.
When you look at the literature too, there's like this 1,300-page document that looks at prenatal nutrition. And right in this document, it says that the lower limit of dietary carb compatible with life apparently is 0, provided the adequate amounts of protein and fat are consumed. So like right in the document, they say that carbs aren't necessary, but go ahead and eat 175 just for safe measure. The other thing is that when you see your obstetrician, frequently people will check urine. I get asked about this a lot, and they test for ketones in the urine. Urinary ketone levels do not correlate with serum ketone levels in pregnancy. So I pulled a bunch of studies looking at this, and even in women that had like sky high ketones on urine, the serum ketones were never above 0.3. And so that's, something to really note is if your doctor freaks out because there's ketones in your urine, I promise you your serum levels are not at a dangerous level. In the 3rd trimester of pregnancy, which is the more catabolic state, there are more ketones circulating in the mom's bloodstream. And in the 3rd trimester, those ketones are actually helping provide an energy substrate to the baby's brain, actually myelination of the baby's brain. And there was a study that looked at the time of delivery, a mom came in to deliver and they checked the mom's serum ketone level, and then they looked at the umbilical cord levels of the baby's ketone level. And the baby's ketone levels were significantly higher than the mom's, which means that the body was actually shunting more ketones to the baby. The baby's producing its own ketones. And those ketones play an extremely important role in the brain development. And so, back to gestational diabetes for a second. So when women develop gestational diabetes and we have this, hyperinsulin state and all this excess insulin, it causes large for gestational age babies. And it also, I had mentioned earlier, can change the epigenetics of these children. So they're starting to look at now the babies in utero that were exposed to these high levels of insulin, and they're looking at them all the way into their teenage years. And what we're finding is that babies who are exposed to these high blood sugars and high insulin levels in utero actually have a 6-fold increase in obesity and blood sugar problems by the time they're a teenager. So we can't just say, eat 50 carbs with each meal if you have gestational diabetes. Like, I know this is unpopular what I'm saying, but low carb is safe in pregnancy. And especially if you have gestational diabetes, you need to restrict carbohydrates to a level where your blood sugars are normal. The answer is not to give the patient more insulin.
More insulin, which is going to change the epigenetics, like you said.
Right. And so a common question I get from a lot of followers is about the glucose tolerance test. Hey, I don't want to do the glucose test. What are my alternatives? my best recommendation is to just ask for a glucometer. What you really want to know at the end of the day is what your blood sugars are doing. And so, eat your regular diet and test your blood sugars, or, stay on your low carb diet. The thing that the low carb keto people need to understand also is that you are more likely to fail your glucose tolerance test.
Yes.
Your pancreas is not used to, and I think it was a podcast I listened to with Ben Bickman, his wife. This happened to his wife. But
Yes.
I would just, if you are low carb during your pregnancy, refuse the glucose test and ask for a glucometer, check your blood sugars for a week and just prove that they're normal, because you will fail the glucose tolerance test. And
it doesn't mean that you're insulin resistant. It doesn't mean you have diabetes. He calls it glucose intolerant. And this has been talked about in a lot of podcasts, the idea that when you are ketogenic, when you are low carb, if you are carnivore, your body is not expecting glucose. And so the GLUT4 is not in the membranes, and your body will have a hyperinsulinemic response, a hyperglycemic response. Doesn't mean you are insulin resistant. It means you are glucose intolerant. If you then go back a few days later, it will be normal. So you can either eat a bunch of carbs 3 or 4 days before, which will correct it when you do the glucose tolerance. But I think your idea is better. Just use a glucometer. You'll see your blood sugar's fine. It's this artifact. So don't be swayed by that either. I love that you pointed that out.
Right. And I mean, I hate for people to have to poke their finger, but at the end of the day, what you really want to know is what your blood sugars are doing. So just get the glucometer and check your fasting and 2-hour postprandials and, see what they are. There are some women, even, moderate low carb, that have, like, I've seen women where we test and they're still having high fastings in the morning. And so we still sometimes have to make more manipulation of the diet. It could be a cortisol effect, but just check your blood sugars and just know what they're doing, because at the end of the day, that's the best thing for you and your baby. So then what happens is in the 3rd trimester, like I said, we have these high ketone levels in pregnancy physiology, as high as, like, I think it was 2.2 millimoles in the umbilical cord of some of these babies. And then breastfed babies have higher utilization of ketones, more than 30%, because breast milk is high in MCTs. And so my recommendation for breastfeeding moms, because I have some moms who will reach out and say, hey, I just delivered my baby, I'm ready to go keto now. And I would be very cautious in the first 8 to 12 weeks postpartum, all of a sudden going, low carb or ketogenic if you're not already keto or fat adapted. But they've looked at studies in patients who eat low carb and ketogenic, even 8 to 12 weeks postpartum. And I think that the lower carb group was like 137 carbs per day, which is really more like moderate carb.
That's not a lot, not low.
Yeah. And there was no difference like in supply, or baby's weight or anything like that. So my recommendation is you can breastfeed low carb, just don't cut your calories too much. So breastfeeding women need about 500 additional calories per day. Watch your hydration and watch your electrolytes. That was something I was going to mention about the cortisol. There was one study, this is not related to pregnancy and breastfeeding, but there was one study showing an increase in cortisol. I think it was a rat study, but the subjects were hyponatremic. So with electrolyte imbalances, they saw an increase in cortisol.
So then they had low salt in the serum is hyponatremia. So
which could happen to somebody on carnivore or low carb, if they don't replace their salt and then they see a spike in cortisol. So I'm glad that came back to my mind. But no, with breastfeeding, completely safe. Ketones are great for the baby. And then it isn't until the baby turns 6 months old. And the recommendation is like oatmeal and rice cereal.
Oh, it's so crazy.
And then they turn 2 and they're on the goldfish diet. And it's like,
that's a whole other podcast. That's so, it makes
set up to be addicted to carbs for the rest of their life.
And I mean, people have talked about this. Amber O'Hearn is someone, there are examples of women who have had carnivore, ketogenic pregnancies. Michaela Peterson has been carnivore throughout all of her pregnancy and, her breastfeeding and delivery and, and so one of the things I've heard Amber O'Hearn talk about and other people is that children go into ketosis like that. If children, breastfed babies have ketones even between breastfeedings. Like this is, again, it's not starvation physiology. We can just flip back and forth. And, if even kids, toddlers, young kids, like they're going to have ketones all the time. It's not a bad thing. It's good for their brains. And I love that you pointed out that in utero, ketones are used for metabolic processes in the brain and crucial for myelinization of the neurons. So kids don't fear ketones, and we shouldn't fear kids being in ketosis. I think that what we should fear is we want to make sure people are getting enough calories. We want to make sure they're getting enough micronutrients. And those two can get confused. Ketogenic diet, you just need to make sure that, if people are breastfeeding and they're ketogenic, like you said, they get adequate calories, they get adequate fat, they get adequate micronutrients, and make sure you get adequate electrolytes. One of the things I'll just add here, going back to the cortisol story, is that when people go keto, they will drop their insulin. Now, it takes the body a little bit of time to adjust to the electrolyte levels, and people will have trouble holding on to salt if they're going from a high insulin state to a low insulin state. So they'll need to up their salt intake, and they'll need to watch that carefully. Once you get fat adapted, your body generally gets better at holding on to salt. But one of the things people think that a keto flu is actually you get hyponatremic and you get low electrolytes because you're switching over your physiology. So the hyponatremia is really key. So if you're getting electrolytes, you're getting enough calories, you're getting your micronutrients, it's not a big deal.
Well, and what's interesting that you bring that up is that the current recommendations, if you look at the recommendations for carb intake on for pregnant women right now, it would be impossible for them to get the micronutrient content that they need for their baby while consuming that many carbs. Because unless, it's just like, it's bread with like added B vitamins and crap in it. So, when we look at what is optimal prenatal nutrition, things like eggs, egg yolks, liver, meat. Things that have, but like for instance, the uterus in pregnancy, right? It's like giant muscle, but we see this expansion, like 800% increase in collagen just in the muscle alone. And so, you talk about glycine methionine ratio, like they need more glycine, like they need more collagen. Like I recommend all my pregnant people should be on a collagen supplement.
That's amazing.
And one of the theories too with stretch marks is that that they don't have enough glycine.
Ooh. That's fascinating.
So, it is what it is, and it's completely safe. And I take care of a lot of patients that eat this way. And we know anecdotally, there's lots of people that have perfectly healthy pregnancies, but it's all going to be observational. We can't do randomized control trials on pregnant women.
No, I think you bring up a good point, and people will sometimes, offer that against a carnivore diet or a ketogenic diet. Like, well, where's the evidence? And it's like, look, talk to physicians, talk to people who actually see patients, and they'll give you their data. And that's why I wanted to have you on. And I think it's been so cool because you're dealing with pregnant women. I don't see pregnant women in my practice, and I don't have any clients that are pregnant right now. I see women and I see their hormones, but you see more of that than I do. And so it's going to be doctors like you and I who are treating people with carnivore diets, with ketogenic diets, saying, hey, I've been in practice for years. I've seen thousands or hundreds of patients, and I don't see that. This is not working clinically. And then we'll get pilot trials. But, I think for people to say there's no data is to say, well, anecdote is still valuable, especially when it's in a medical context. And, maybe we just all need to start writing up a million case studies. But the clinical people who are seeing this are really providing a valuable set of information. It's not codified into RCTs yet, but that doesn't mean that we can't make, inferences and tell people how this might be good. So, well, this is awesome. So I hope people got a lot out of this. I think this has been an amazing conversation. I think people are just like probably super stoked right now, and they want to reach out to you. They want to see you in clinic. How do people find you? Where are you? All over the place.
Yeah, so I'm a board certified obstetrician gynecologist in Omaha, Nebraska. I'm at Mid-City OBGYN. And you can find me on social media, Dr. Fit and Fabulous, on Instagram, Dr. Fit and Fab. I do have a website, drfitandfabulous.com, and it does have a link to the clinic. So if you're a local patient, you want to visit, call the clinic. I do online virtual consults online, and all that information is on the website as well.
If people want to get an online virtual consult with you, should they do it through the website? Can they email you directly? How do they get in touch with you? Is that through the website? Is that the best thing?
Yeah, my email is on there, and you can book everything right through the website.
Awesome. I think you're probably going to get a few people talking to you right now after this. Well, thank you so much for coming on. It's been a real pleasure. I hope this has been helpful to people. I'm going to post this on YouTube and iTunes. And if people are watching on YouTube, leave comments below. We'll try and answer them, and we can hopefully reach out to people. But reach out to Dr. Seeman on Instagram, and there's so much information happening in here. Thank you so much for coming on. It's been a pleasure. I really appreciate it.
Thanks.